Welcome to Joint Effort with Des Moines Orthopaedic Surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Welcome to Joint Effort. I'm your host, Jason Sullivan, here with Dr. Ian Lynn.
I didn't know who you were, so thank goodness for your introduction. Thank you.
Thank you for coming on. We appreciate having you.
Thank you.
Our task today is to talk about maybe the most important structure in all of orthopedics, but maybe also the most boring, as you said, the meniscus.
Yeah, it's great stuff.
It's a very common operation, so we need to cover all the details for people. Before we get there, though, I don't think many people know how big of a baseball fanatic you are.
I am a baseball fanatic.
I don't know if is fanatic the appropriate word?
Yeah, maybe that's a bit aggressive. I love baseball. There's no two ways about it. I played baseball. I played in high school. I played in college. Then I coached baseball for so many years. I don't know what to do with myself.
Where does your interest initially stem from?
Well, my dad was a baseball player, so he grew up in Taiwan, and in Taiwan they had a national team. So when my dad was 10 years old till when he was 12 years old, he was the only pitcher of the Taiwanese national team.
Today that would never fly, right?
That would never fly. There's no 80 pitch count back then. So my dad literally was the only pitcher. And back then in Taiwan, they didn't really have to go to class. All they had to do was pass
in like sixth grade, fifth and sixth grade?
Yep. All you had to do is pass the level of tests every year. So instead of going to class a lot, they would practice. So they would practice 6-7 hours a day.
Wow.
And they used to practice on this red cinder, and they used to do it barefooted. I'm not sure if these are some stories my dad told me, so they're probably half truths.
Right. He walked up the old school both
That's
ways.
Right. That's right. So they literally practiced that way. And in Little League, you can't lead off of first base. They played like the pros. You could lead off of first base. You could pick people off. It was just like that.
So they were far more advanced than even we are today.
Far more advanced, and he was coached by his older brother. So.
Okay.
So
wow.
It was
How does that work? Big age discrepancy there?
Pretty big, yeah.
Okay.
Yeah.
So he was a pitcher. That was his position.
My dad was a pitcher, but he could play anything. His nickname was sort of like, it would be in Taiwanese, it would be something, but in United States language, it would be like Mighty Mouse.
I love that.
Because he was tiny. He was very, very tiny.
Can I call you Mighty Mouse Jr.?
Yeah, I'm a big guy, though, so, yeah.
Are you bigger than he was?
I am considerably bigger than he is.
Okay.
Well, but back then, my dad, he was about 5'10", and he was a stud. He played all the sports. He played basketball, volleyball. He played baseball. He ran track, and he was very, very, very fast.
How hard could he throw as a pitcher? Do you have any idea?
I don't know
how fast. So you were born in Boston.
I was born in Boston.
And that's why I see the Red Sox hat every once in a while.
Oh, I love the Red Sox. Yes, I love the Red Sox.
They're on hard times right now.
Well, they usually have a down year, then they have an up year. You never know.
They've won 3 World Series in the last 15 years.
They won some World Series recently, so we're pretty pleased about that. But so have the Cubs. So they won one.
Singular.
So the Cubs, they're my Midwest team. So
okay.
I've had a good lately.
You had a really good run. Yeah. So you've told me this story before, but tell everyone about your first at bat at Grinnell College.
So at Grinnell College, we used to, that was the only year that I remember going down there. We went to Ranger, Texas to play Ranger Junior College. And Ranger, Texas is so far away, and it's in the middle of nowhere. And we stayed at a place called St. Elmo's Fireproof Apartments, and there's no
Very
door
high.
to it.
4-star, for sure?
Minus 4 stars, exactly. Literally, to get into the place, you had to go up the fire escape. So we're not expecting much. But we go out to the field, and it's a beautiful field. And there's this guy warming up, and he's this big lefty. And someone goes, "Oh, my gosh, that's Pedro Borbon Jr." It's like, Pedro Borbon Jr.? Pedro Borbon was a Cincinnati Reds.
Oh, this is his kid.
Yeah, this is his kid. I think Pedro Borbon was like a Hall of Famer for the Cincinnati Reds now.
Okay.
So this is his kid, and he throws heat, And so I go up to a bat. And
are you lead off? Or
I am batting third.
Okay.
So he struck out the first 2 guys. So I come up, and on the way up there, I found this little plastic thing. It looked like a brush. And I said, oh, this is a brush like you're brushing off home plate, so this is going to be my lucky charm of the day.
Right.
So I put it in my pocket,
Right.
put on my batting gloves, and get up there, and he throws a first pitch fastball at me, and it just, I was like, oh, that's pretty fast. But
You watched it?
I watched it. I didn't swing. This is my first at-bat, and then next pitch he throws a curveball, and I hit it, and it feels good. And the wind is blowing out, so I won't say that it was all my power. The wind was blowing out, and I hit it, and I start running as hard as I can to first base. And just as I'm running first base, I clipped my cleat on first base, and I fell down face first in the Texas dirt, just covered. And I'm just like, oh, I'm so disappointed.
You're going to get thrown out.
I'm sitting here going, no, I didn't get a double. I thought I smacked that thing.
Yeah.
So I'm standing on first base just so mad at myself. I'm brushing myself off, and the umpire goes, son, you going to go all the way around or not?
Touch them all.
I was like, what? I didn't even see that it
Missed
went
the
out.
leaf.
No, heck no. I only had one home run in my entire life at
That's
Newton.
hilarious. Oh, my God.
So the second time I bat,
Yeah.
same exact thing. I hit another ball, and it hit the fence. It was a double, and I made it to second without tripping.
You were this guy's kryptonite.
For those two at bats, and he struck me out. So
Okay.
it was a fast game. It was a fast game.
We don't need to hear the end of the story.
Yeah, I wish you wouldn't have gone
that's
that
how
far.
it began. Well, if anyone knows you in town, we all know you to be very passionate about helping high schoolers and even grade school kids kind of develop their baseball skills to the point where, didn't you put a batting cage in your house or your backyard or something?
Yeah, I have a batting cage in my garage.
Okay, that's normal.
Yeah, it's normal. Isn't it? You can hit all year round.
Did your kids have a choice on what they played?
No. But the funniest thing is that my kids all played baseball, but my sons also started the rugby club at Roosevelt. So they were part of that first team that back in, I don't remember how, it was 2010 or something, they started rugby.
You figure built-in business for DMOS, right?
Well, my son Aaron, who ended up playing at Iowa at rugby, he did tear both of his ACLs. So,
no way.
Yeah, and yeah.
I didn't know that. So how many do you have left in the house right now?
I have only one.
And he is going to be a senior?
Nope, he's a freshman this year.
He's only a freshman?
He's only a freshman,
Okay.
yeah. So I got graduated from college to freshman in high school. So anyway.
And he's an aspiring baseball player?
He's a good baseball player, yeah.
Don't you coach the Roosevelt High School kids in the off season?
I do, yeah. I've been doing that since 2010. As much as I can. It's obviously hard as an orthopedic surgeon to do that, but yeah, I've been doing that since 2010, and I still do. We started this year already, but with this COVID stuff going on, that we've had to shut that down.
So we're going to talk about meniscus, but I think that people will be curious, because everyone hurts their arm. All these little leaguers hurt their arm.
Yeah.
So from your perspective, what do you do to keep them fresh so that they're not hurting themselves come time for the season? Is there any magic sauce that you have that you figured out?
No, we do a lot more strengthening than we used to. So when I first started this, we were just stretch, and then you'd throw, warm up a little bit. But now we do a lot more strengthening ahead of time. And so I think that has helped. But we do not necessarily follow pitch count, but we definitely don't overthrow anymore. We know that there's limited throws in everybody's arms, so we're not overthrowing them when they're 8 to 14.
Right. So. Okay. All right. Well, that's a fairly valuable thing to have an orthopedist guiding your son's throwing program. I mean, you don't get that every day.
No, you don't get that every day.
That's awesome. All right. So let's move on to the meniscus. Everyone comes in. I would say 80% of patients come in kind of knowing what it is. Like they read about it, they kind of look it up.
It's easy to find.
What is it to you? Describe. We have two different kinds of meniscus. Describe the structure to me and how you talk about it to a patient so they understand it.
Yeah, I think it's relatively easy because everybody knows that it's some sort of shock absorbency. But I think of the meniscus as much more than that. Not only does it absorb shock between your thigh bone and your shin bone, but it also provides some stability because if you look at a meniscus in cross-section, it's sort of triangular shaped. And it does form a little bit of a cup, and it fits the femur very nicely, both on the medial and the lateral side, or inside and outside of the knee. There are two menisci. They look different, but they function relatively the same. The lateral meniscus is smaller but wider. The medial meniscus.
And when you say lateral, we're talking outside.
Outside, yep. And then the medial, which is the inside, it looks bigger, but it's thinner. And that's the one that we seem to tear the most because there's a lot of forces that go across that medial joint space.
And in your practice, you see all sorts of injuries. The knee is, if I had to guess, you probably do more knee than anything else in terms of joint-wise.
Knees and shoulders, yeah.
Knees and shoulders. So knee being a focus of yours, obviously, you're seeing a lot of meniscus injuries.
Yes.
Describe for me, someone comes in, what is the workup? How do you figure out, can you figure out they have a meniscus tear before you've even examined them based upon the way they tell you the story?
Yeah, the history is so important. I think that when you hear someone and they tell you, yeah, I came in, I was walking down the stairs and I twisted funny and all of a sudden I had a sharp pain. And since then it's been, something's feeling wrong in my knee, like it's catching. Then you almost always think meniscus first. Or if they've had a twisting injury on the football field and maybe a little bit of swelling but not a lot of swelling, so you're not thinking it's a ligament injury, then you start to think meniscus.
Right.
Especially if they have those mechanical symptoms, the sharp stabbing, catching, popping pains, and especially if it's in a specific joint space.
And they usually come to see you because, does it hurt all the time, or is it with specific things they'd want to do? Or
Well, I had 2 patients today, so this is a perfect example. Yeah. I had one person come in today and say, man, my knee's been bothering me for 8 months, but it's only when I squat down to like do cleaning or like I'm wiping the floors or mopping, and I was like, oh, God, I'm not, I don't have that problem.
Can I get you notes so you don't have to do that at home?
Here's a prescription. And then I had another one who was actually playing a sport, and then they stopped, planted, and twisted, and all of a sudden they can't straighten their knee out. So 2 different scenarios. One is more chronic, one is more acute. I don't see as many as acute ones as I see more of the ones that have gone on for a while.
Yeah.
So my patient population is a little bit older. And so the ones that are acute, they're a little bit more swollen, they're a lot more tender, and if they can't fully extend it, sometimes the meniscus can actually flip up and block their motion, and that's when you get really concerned. Mm-hmm. And the more chronic one, though, you can tell usually by exam, they say, I'm the tender right here in this joint space. It's not on the other side, it's only on one side. Yeah. And then when you do a special test, we call the McMurray's test, where you're kind of twisting the knee, sometimes you can feel a click. Sometimes it's just directly tender in that spot, and that gives you clues.
They almost wind up like they want to punch you sometimes when you
when it clicks really good, they don't like it.
For sure. So that brings us right into the next topic for discussion. The meniscus, you just described them perfectly. I'm guessing, based upon those 2 scenarios you presented, you're thinking these are different kinds of tears, right? Like not just acute versus chronic, but maybe a different tear pattern.
Sure. When I think about menisci, I think there are different tear patterns. One would be like the horizontal tear, where they're like a cleavage tear, where it splits down the middle. Then we have radial tears, where it goes from the inside to the outside, but in a straight line.
I don't know about you, but those are bad actors, I feel like.
The radial tears are tough for me because, as we'll talk about, I'm sure, is the blood supply, the meniscus. Those are really hard for me because it's such a small-looking tear, but it causes so much pain, and they're hard to fix. So you might try to fix some of it and leave some of it. It's hard.
And they usually start on the inner third, where there's not very good blood supply.
Yeah, that's the problem with the meniscus tears. Only the outer, I always tell people 25 to 30% of the meniscus has good vascularity. Then there's an area where there's another, let's think of it in thirds, I guess. The second third would be okay vascularity, but not great. And then the inner third, there's really no vascularity.
Right.
And so if you try to fix something in the inner third, there's just not going to work. It's not going to work. And that's why radial tears are tough, because it starts in the what we call the white zone.
Maybe in a kid, like a teenager, you could consider fixing it, because if you can get 50% of the outer part to heal, and then maybe if you have to come back and clean up the inner 50%, it's still probably a win. But some of those radial tears cut all the way through.
Yeah, and those are the tough ones. But I would consider putting a stitch in it just to hold it together and hope that some of it heals.
Right.
To preserve. Because if you think about it, if you try to ellipse out that tear, I mean, the further it goes back to the edge, the much bigger you have to take out, because otherwise you're leaving lips for it to get caught.
I think a hard thing in clinic to talk to patients about, they always say, well, what should I do? They have a meniscus tear, and let's say they don't have much arthritis, and they say, it bothers me this and that and the other, but I can work around that. It's sometimes hard for me to guide them. Do you tell them? Do you tell any people that, hey, we need to get this out? Could it cause more problems by leaving it in there?
If they're having mechanical symptoms, if they're really having a lot of catching, you scope knees when sometimes you see these flap tears, and then you can see them irritating parts of the joint cartilage.
Right.
So I don't like them when they're catching. But if they're just complaining of a generalized achiness, if they overdo it, and if they don't overdo it, then they're relatively good. I tell people to live with it as long as they can.
Dealer's choice.
Especially if they're older, because you're not going to fix them.
Right.
But but the younger kids, they're usually more acute, and so they're a lot more painful. Those are the ones you worry about the most, because if you want to fix them, you want to get to them early.
Yeah, for sure. No, I agree. Now, to if you say, hey, we need to do surgery here, everyone's seen some, and I don't know if in your training how far it goes back, but everyone's seen the scars of an open meniscectomy, what that used to mean. Did you do any open meniscectomies back in the day?
Very rarely, but that was still not necessarily in vogue. But when I was training in the early 90s, I saw, and we certainly saw way more of those back then, because the total meniscectomies were probably in vogue till maybe the early 70s. Mm-hmm. Then they realized the importance of it, and then everybody started cutting down on it. So
when you say cutting down, you're saying trying to preserve some good remaining meniscus, correct?
My strategy has always been leave as much as possible. Even if you have a horizontal cleavage tear and you're taking out just the bottom half and leaving the top half, even though I'm not sure if that's great either, but at least you're trying.
Yeah.
Because you can't fix it. I don't think those are fixable, especially if they don't go all the way to the edge.
What happens when you have a tear that is just not fixable? It's torn in multiple planes and you have to take the whole thing out. Why is that bad for the knee?
Well, like I said, the meniscus is important for shock absorption. So I would say that if the meniscus is intact, it literally transmits 50 to 70% of the load from the femur to the tibia. The problem is if you take it out, then not only do you lose the load absorption, you can probably increase the contact forces across that joint probably 2 to 3-fold.
Okay.
And so thus you have a much higher chance of arthritis. Plus, remember, the meniscus is important for stability. So think of like a baseball sitting in a cup. And if the baseball's sitting there and it's nice and stable, but let's say you remove half of it, all of a sudden that baseball can travel. And that's what I think about in the knee. So that meniscus is important for the stability too. And that slight translation can cause more damage to the joint cartilage as well.
So a really hard conversation is that like 16-year-old kid who has a fixable bucket handle tear and they're in the middle of their football season and the family and the kids say, take it out, I want to play. Because there's differences in recoveries, right, with repairs versus meniscectomies. Yep. Can you describe kind of how you navigate that with your patients?
Well, it's funny that you mentioned that, because I had an elite wrestler here in town whose scholarship demanded that he win state.
Whoa, really?
Yeah, it was basically contingent. That's my understanding.
Wow.
So he had a bucket handle lateral meniscus tear, and his father wouldn't let me fix it. And it was a struggle to take that thing out because it was fixable. Mm-hmm. It just went against my queasy. I was very queasy, but he ended up winning state.
Really?
I had to suck out his knee before he actually wrestled, just so he could win state.
Really?
And he doggone if he didn't win it. And he went on to Division I college wrestling.
Wow.
And in
that case, you probably say it's worth it, right?
$250,000 to a...
Yeah, that's an expensive meniscectomy. You saved a lot of money for Dad.
But the conversation is that I tell all my younger kids, if I can fix it, I'm going to fix it. I know the hard ones are the seniors. It's the last season. Boy, it's tough. Well, I had another one who had a previous ACL reconstruction. She had a meniscus tear, and it was bucket handle tear. She tore it playing soccer again. Mm-hmm. And the worst part is she had an MRI scan prior to done by somebody else, and they said it was a meniscus tear, mm-hmm. and they didn't do anything about it. She went to play, and sure enough, it tore. Yeah. So I had to have the conversation that I'm fixing this because she's an athlete, she's a dancer, and I was like, I have to fix this thing.
Now, fast forward, 25 years of orthopedics that you've probably seen over your career, and you're doing these through an arthroscope.
Yes,
which means for the most part, through small incisions.
That is correct. I try to do them all inside. We call it an all-inside technique. We used to do the inside-out technique where you'd make an incision on the back of the knee, and then and you literally use a spoon to catch suture and pass or needles, and then tie it on the outside of the knee, which actually worked very nicely. I tell you what, that's the gold standard in my book.
Inside out's amazing, right?
It feels so good when you're doing it.
You can get so many good stitches, and there's no problem at all fixing meniscus that way.
No, well, it's hard.
It is. It's not easy.
It's not easy.
How do you? So, some of the smaller implants now, do you fix some of them all inside where you're doing it through the scope and you?
I try to do them all inside now because I think the way these sutures are made now, and they're very low profile, and they have these anchors that fit up along the capsule, and then when you cinch them down, you can actually see the meniscus skin pulled to the capsule. It's pretty satisfying, actually. I think that their technology is a lot better now.
Do you do anything to roughen the capsule up or create bleeding back there?
Yeah, and that's important. I think that I've done it two different ways. I'd like to take a little bit of a shaver or a rasp and rasp the outside to roughen it up and kind of stimulate some bleeding. I've also taken needles and just poked holes along there. We call it trephination. I don't know if it helps or not. Who knows works better, but and then when you fix it, I just like to fix it. And I like to spread them out about 6 or 7 millimeters or even more, and try to get a few stitches in there.
Now, why was the dad afraid of you fixing this kid's meniscus tear? Tell us about the recovery when you fix a meniscus.
Well, when you fix it, it's protected weight-bearing inflection for probably a good 4 to 6 weeks, because of the shear forces across that, and he wouldn't have been able to wrestle.
Right.
And that's the problem. And then I'm pretty aggressive after that with closed chain and open chain exercises where you're just working your quads and your hamstrings. Again, the most important thing after your meniscus repair is strengthening your knees, because that's what's going to give you stability.
And what are your thoughts on getting back to sports after a repair? What's your timeline typically?
After a meniscus repair?
Yeah.
I kind of treat it like an ACL. It's almost like 6 months. Yeah. And I think
it's almost harder than an ACL.
I honestly think that I get more nervous about sending a meniscus repair back than an ACL.
Well, when you're doing a repair of the meniscus, at least in my mind, you're almost hoping you're doing an ACL, because I think the healing rates are a little bit better.
Right, and that's a great point, because again, stability is important, right? So if you have a ligament tear in addition to like a bucket hand meniscus tear, you should fix the knee and get it stable as you fix it. Number one, it'll give you much better chance for it to heal. Number two, the bleeding, extra bleeding that you get from fixing a ligament actually can help stimulate healing as well.
And on the flip side, if you have a simple little tear, you get in there, okay, this is an inner third tear, I'm going to be able to preserve most of the meniscus. You're using little instruments to bite that out and smooth it off? Is that
that's the beauty of arthroscopy, is they have specialized instruments that have little tiny heads. You can't even believe that. But then when you put them in the camera, they look huge. They do. These little things just bite out just a nice little amount, and some of them are rounded, some of them are curved up, some are curved down, curved to the right, curved to the left. So you can get to almost everywhere you want to and do a really good job of trimming things up.
And maybe the biggest dichotomy in sports medicine is telling people that after that they can play in a couple weeks, right? So then they're thinking, well, why wouldn't we just take them all out? And that's why you have to re-engineer the conversation. Well, if you're taking it out, you might get arthritis in an earlier age. But that recovery is pretty quick with a simple meniscectomy.
Yeah, 2 weeks may be a little early for me, because again, my population is a little bit older, and so I kind of insist that they give it a little bit more time, strengthen the legs before they try to get back to normal activities. But I've had people play the game with their stitches in too, and that just drives me crazy. But you're just like, well, I guess that's it. But that conversation is very difficult, because when you say, well, if I take it out, actually you'll be probably feeling pretty good in 2 to 3 weeks. If I fix it, more like 6 months. That's a hard thing to tell people, but most of the parents get it. Most of the kids cry.
Yeah, it's true.
Tough. It's tough. I mean, especially these seniors. I feel so bad for them. They're the toughest ones.
Now, last scenario that I think everyone wants to know about. In an older population, a 65, 70-year-old has pain seemingly stemming from the meniscus, and you get an MRI to kind of look three-dimensionally at the knee, but then you discover there's a fair amount of arthritis. How do you walk people through that scenario? Because you also do knee replacements, correct?
Yeah, I do a lot of knee replacements. Now, this is a great thing to talk about because a lot of times people come in and say, my primary doctor got this MRI scan of my knee and it shows a meniscus tear. But they didn't tell them that, well, your bone is bruised, your joint cartilage is completely eroded. Well, to be perfectly honest with you, knee scopes don't help that patient. With the caveat that if you're having significant mechanical symptoms and it wasn't hurting before and it's just catching,
right,
then maybe I would do it. But I'm very hesitant about doing an arthroscopy on a truly arthritic patient with a degenerative meniscus tear.
If their x-rays show they have decent joint space, though, and they had a new injury, you'd consider doing it to
Absolutely.
try and buy as much time on that knee as possible.
Yeah. Again, I typically try to limit it to those people who have mechanical symptoms. I don't do it just for generalized achiness because I don't think it really helps. Now, again, a lot of my patients come in several months and this has been bothering, so it's already too late. They're gonna get their scope because that's what they've been told that they need.
Right.
So,
some people come in and they know what they need, and if it's reasonable, we do it for them. But sometimes you say, "Hey, this is not what you need."
That's right. It's a hard conversation because then a lot of times they'll go somewhere else.
And that is true.
That's true.
And as you said, when the meniscus is torn, you have those increased contact forces. So on MRI, you see those bone bruises, and that's when you know this might be too far gone in some cases for me to reverse this and make them completely better with the scope.
Yeah, and that's one of my major conversations, and I always tell them, if it is catching on you so much that you're having a hard time doing your daily activities, that's the only reason to do your surgery. Because if it's just a generalized achiness, treat it more like arthritis. Give them some cortisone shots, some other, stem cell injections, hyaluron gel injections, those kind of things, and treat it more like arthritis.
Well, this has been awesome. A lot of good information here. People don't realize that a meniscectomy is the most common orthopedic procedure.
It's crazy, isn't it?
If you look at every one of our practices, everybody, if they have a busy day, you typically have a meniscectomy on there somewhere, right?
Yeah. Just think that it was up just to the 1970s. People were just making an incision, taking them all out.
Right. And now we can take a little portion out, and in 4 to 6 weeks, hopefully back to the livelihood they want to be at. And
that's our goal.
It's been a large part of what we do in helping people's lives. So thanks so much for coming on and talking about this.
Hey, thanks for having me.
Thanks for listening to Joint Effort, a podcast from Des Moines Orthopedic Surgeons. If you have questions about this podcast and wish to schedule an appointment with the surgeon, call 515-224-1414 or visit DMOS.com.